Hi, I'm a rheumatologist, and today we're breaking down the classification criteria for ANCA vasculitis. If you are interested in learning about the pathophysiology and clinical manifestations of ANCA vasculitis, please head to my last video where I discuss that in detail. Now, the diagnosis of ANCA vasculitis depends on clinical findings, imaging findings, lab findings, and when feasible, a tissue biopsy. Let's talk about ANCA testing first. The vast majority of people with ANCA vasculitis will have a positive ANCA antibody, but there is a small percentage of people with ANCA vasculitis who have a negative ANCA antibody, and so a negative test does not necessarily rule out the disease. GPA is associated with PR3 ANCA, which presents with a cytoplasmic pattern on immunofluorescence, or c-ANCA. MPA is associated with an MPO ANCA, which produces a perinuclear pattern on immunofluorescence, or p-ANCA. In eGPA, only about 40% will be ANCA positive, and those that are positive will usually have an MPO ANCA. Don't worry, I'm going to explain this to you. c-ANCA and p-ANCA refer to the patterns that the lab tech sees on immunofluorescence when they expose a neutrophil to the patient's blood. The difference comes down to where the target protein lives inside the neutrophil. This determines where the antibodies will cluster and glow. So imagine a neutrophil as a fried egg. You have the yolk, the nucleus, and the cytoplasm, which is the egg white surrounding it. Now imagine dipping that egg into a sample of the patient's blood that contains the ANCA antibodies. The antibodies will bind to their target protein and they will glow under immunofluorescence, and the pattern tells you which type of ANCA it is. Where the glow appears tells you the pattern. When antibodies bind to PR3, then the glow spreads throughout the cytoplasm. This lights up the egg white while the egg yolk stays dark. This scattered grainy glow is called the cytoplasmic pattern, or c-ANCA. When antibodies bind to MPO, the glow looks like it sticks around the nucleus, so around the egg yolk. The egg white remains dark, and this is called the perinuclear pattern, or p-ANCA. Now, before 2017, they first did fluorescence testing to look for those ANCA patterns, and then if they were positive, they would look for the PR3 and MPO antibodies. This had several limitations because fluorescence reading requires humans to look at the patterns, and humans can disagree. Also, p-ANCA is not specific to vasculitis at all, and people with inflammatory bowel disease, autoimmune hepatitis, rheumatoid arthritis, and infections all can have a positive p-ANCA. So from 2017 onward, the new approach just uses immunoassays to look for PR3 and MPO ANCA in the blood. Now you understand ANCA antibody testing, but what about that subset of ANCA vasculitis patients with negative ANCA antibodies? How is that possible if the ANCA antibody is so central to the pathophysiology? Reason one, the antibodies are there, but they're hiding. Some patients have MPO antibodies, but their MPO antibodies latch onto the part of the MPO molecule that is physically covered by a blood protein called ceruloplasmin. When the standard lab test looks for that MPO antibody, they can't see it because it's physically covered by the ceruloplasmin. Imagine trying to find a specific key on a keychain, but somebody has wrapped that key in tape so that it no longer looks like that particular key anymore. When researchers stripped away ceruloplasmin in the lab, the antibodies became visible. So in these types of patients, the antibodies are real and pathogenic, the test just can't find them. Reason two, the antibodies target an unusual spot. Think of the MPO or PR3 molecule like a large building with many different doors. The standard lab test checks whether antibodies are trying to get through the main entrance. Some patients make antibodies that target a side door, a less common entrance. These antibodies can still activate neutrophils and cause disease, but because they're binding to an unusual area, then the lab test may not detect them. Reason three, the disease showed up before the antibodies did. Think of a fire. The match that starts the fire is not the same as the gasoline that causes it to spread. In GPA in particular, the granulomatous part of the disease is triggered by T cells rather than by ANCA antibodies. The ANCA antibodies may come later, like pouring gasoline on a fire that is already present. This is supported by the observation that people with ANCA-negative vasculitis can sometimes seroconvert over time and become ANCA-positive, and when they do, they can have new organ involvement. Reason 4, T cells can cause damage on their own. Remember, T cells, the generals of the immune system, can form granulomas and cause damage even in the absence of ANCA. Reason 5, in eGPA, ANCA-negative eGPA may be a different disease entirely. ANCA-positive eGPA behaves much more like a classic vasculitis with kidney inflammation and nerve damage. ANCA-negative eGPA behaves much more like a hypereosinophilic disorder, where the eosinophils are directly invading the heart and lungs and causing damage. Now, tissue biopsy remains the gold standard, but if you have a patient with signs and symptoms of small vessel vasculitis and positive serology, especially if they appear to be declining rapidly, you do not delay treatment waiting for the biopsy. Now, the classification criteria is based on a weighted scoring system that helps you differentiate one subtype of ANCA from another. So for GPA, the single highest weighted item is C-ANCA or PR3 positivity. You get additional points for things like bloody nasal discharge, sinusitis, Posas-Immune glomerulonephritis, cartilaginous involvement, pulmonary nodules, etc. You subtract points for MPO or p-ANCA positivity and for significantly elevated eosinophils. For MPA, a positive p-ANCA or MPO is the single highest weighted item. You get additional points for Posas-Immune glomerulonephritis and for lung fibrosis or interstitial lung disease. You subtract points for a positive c-ANCA, PR3, or significantly elevated eosinophil count. Notice the elegant design here. The ANCA positivity and presence of elevated eosinophils helps you to discriminate the different types. For eGPA, a maximum eosinophil count that is significantly elevated is the highest weighted item. You get additional points for obstructive airway disease, for mononeuritis multiplex, nasal polyps, etc. And you subtract points for c-ANCA or PR3 positivity and for hematuria. So let's recap the approach. Step 1, look for signs and symptoms suggestive of small vessel vasculitis, usually kidney involvement, lung involvement, and upper airway involvement. Step 2, send ANCA serology. Remember to send for PR3 ANCA or MPO ANCA immunoassays, but remember that 10% of patients will be seronegative. Step 3, obtain tissue biopsy when feasible, but do not delay treatment in patients who are rapidly deteriorating. Step 4, use the ACR-EULAR classification criteria to determine which subset of ANCA the patient has. And remember that the classification criteria were primarily made for research, and in real life you have to look at the whole clinical picture and match the history, physical examination, labs, and biopsies in order to make a diagnosis.